So, my topic today is really on cognitive behavioral therapy for depression. So if you came here to really learn about how to recognize depression, this is perhaps not the training that you may have thought. And my subtitle is Tame Your Thoughts. Next slide. This is a slide which we have to show as part of, a part of our my disclosure. And so really I have no conflicts of interest. And so we can move to the next slide. And so my learning objectives today are that you're going to learn about cognitive behavioral therapy, what it's about, what are the principles, what are the techniques, and then how do you assess for improvement in depression in your client or your patient using validated screening tools. Do you, and if you do, how do you actually incorporate that into your treatment plan? That will be at the very end. So again, we are not going to be talking about what is depression, how do you recognize it, that's not the gist of this training today. It's really on cognitive behavioral therapy. Okay, so let's just begin at the very beginning. Next slide. What is CBT? So cognitive behavioral therapy is a form of psychotherapy or talk therapy that focuses on something very, one slide, several slides back, Kelly. Yes, here. It focuses on modifying dysfunctional emotions, behaviors, and thoughts by interrogating and uprooting negative or irrational beliefs. It is considered, by the way, solution-focused or solution-oriented form of talk therapy. And it rests on the premise that thoughts and perceptions influence our behavior, that the way we think and the way we perceive things influence how we act. So feeling distressed, in some cases, may distort one's perception of reality. CBT aims to identify harmful thoughts, assess whether they are an accurate depiction of reality, and if they are not, it helps employ strategies to challenge and overcome them. So that's kind of in a nutshell what CBT is about. Next slide. And so it was founded by Aaron Beck, who is a psychiatrist, by the way, at the University of Pennsylvania in the 1960s. So, it's been around now for a good 50 years or more. And how it came about was that he was very disillusioned with Freudian psychoanalysis, which was at that time the thing, before 1960s. And he wanted to really explore more empirical forms of therapy. What are some other ways for us to really help people? So CBT has its roots in, I don't know how many of you know of rational emotive behavioral therapy, or REBT, which was started by a psychologist by the name of Albert Ellis. And these two were pioneers in changing the landscape for therapy, beginning in the 1960s, to offer patients a new treatment option, which is short-term, goal-directed, and scientifically validated, which is very different from Freudian psychoanalysis. So that's kind of the roots or the origins of CBT. Next slide. So what does it do? What does CBT do? So it is very distinct because it focuses on the present. I don't know how many of you are familiar with Freudian psychoanalysis. It goes way back. But CBT is just the opposite. It focuses on the present, on the now, here and now. What are you thinking right now? What were you thinking when you began to feel anxious or depressed? Are there any harmful patterns that are emerging or that emerge in your thinking? So the goal of CBT is to understand what happens in your mind and your body in the present, and then to help you change that or help you use more adaptive skills. That's basically the goal of CBT. And this is the gold standard for treatment of depression across the world. Especially for adults, if it's a combination of this and medications. For adolescents, just CBT is proven to be more effective than even medications. And there are a variety of CBTs for specific disorders, like you have for eating disorders. You have one for insomnia called CBTI. You have for trauma, you have for children, you have for adolescents. So this is used worldwide, and I'm not going to really go into any of the evidence base because you can just Google it and you'll see all the evidence where they have done multiple random controlled trials on a variety of population, including, by the way, in prisons. How many of you have heard of moral recognition therapy? That is also a form of CBT. So it's being offered in a variety of settings and to different subgroups of individuals. So it has been kind of adapted for that specific disorder. So with that said, next slide. These are the 5 areas that CBT focuses on. The situation you are in, how you think, that is your thoughts. Cognition is just a fancy word for thoughts. What you do, what is the result in terms of your behavior? How does your body respond to all of this thinking that's happening in your head? And then what are your emotions and feelings? So those are the 5 areas of CBT. What is the triggering situation or the event? How you think, what you do, how your body responds, and how you respond with your emotions and feelings. And so next slide. Here I have a nice little a graphic which really explains it to you. So, there's some external event and your thoughts are, nobody likes me. I always mess up things. Look at your feelings, how it affects how you feel, or your emotions. You feel sad, you feel very self-conscious, you may feel anxious and upset. What are the sensations in your body? You may feel tense, you may feel fatigued and have no energy. You may have palpitations, which is your heart is beating rapidly. And what's the behavior? You will withdraw from others because you have a thought that nobody likes you. You stop doing the things you enjoy. So can you see? This is constantly interacting. Each of these little squares are constantly interacting with each other. And that's why the arrows are, kind of in both directions. Thoughts, feelings, body, behavior. And this is really at the crux of CBT. So next slide. So with that said, something we teach in CBT is your ABCs. So the A is and this is a good way to teach if you're doing a psychoeducation for your client. A is what we call an activating event. Remember, I talked about whatever that situation or that trigger is outside of you. It may refer to a real external event. For example, that you get reprimanded at your job, or an external event that is anticipated to happen in the future, or an internal event in your own mind. That means it's a memory or a dream, or just kind of a historical event. So any of that can be an activating event. That's the first A. The B refers to your belief about that subject. What does it comprise of? They include thoughts, your personal expectations of yourself, the world and other people, and the meanings attached to these events. So it's a whole bunch of things that go into beliefs. And we're going to talk about a lot around beliefs. And then lastly, the C is consequences. These include your emotions, how your thoughts or the activating event and the beliefs affect your emotions. your behaviors, and all of the physical sensations related to those emotions. Now, remember that earlier slide that I showed you. So next slide, and here's a nice graphic of what I just shared. So the events are either the world or something with other people, or it could be some personal experiences. It could be your history, whether it's a history of abandonment or trauma or hurt and pain. It could be about the future. It could be about yourself. And look at what impacts all of this. So your attitudes, the rules you've developed for yourself, your demands on yourself, your beliefs, the meanings you attach to all of these things. And that can lead to either healthy feelings or unhealthy feelings. And these could be actual physical sensations. And those very things could also lead to adaptive or constructive behaviors or actions, or very self-defeating actions or behaviors. So again, this is a very good graphic to share with your clients when you're doing kind of psychoeducation. And that's why I've included it. Next slide. So what is your role if you're a therapist or behavioral health specialist in this, in providing this kind of therapy, and the role of your client? Very active. The client must be involved in this process, not as an observer that I'm going to sit passively and observe, or as an occasional visitor, but as a key participant. I'm sorry, when I used my nifty design idea, it cut off some of my text. So it's very key to engage your clients. And I know many of us, especially who work in community mental health programs, we see clients for years, they come in and out. You feel burnt out, they feel burnt out. So this is really a kind of therapy that really involves the client to be a core or key participant. Second is motivation. The therapist needs to take responsibility for helping to motivate the client to change behavior, their affect, and their thinking. They must be able to set up the format, the rationale, so the client will consider change. So very critical. So you see, it's not a very passive process. And then the therapist is directive. The therapist must be able to develop a treatment plan and then help the client to understand, contribute to, and see the treatment plan as a template for change. And I can already hear some people saying, Nirmala, we have an EHR, and it just spits out this plan, which is kind of like an odd template. And I know, because I've used EHRs. I know you have to work within the confines of that, but you can still customize it. And I really want to emphasize here that your treatment plan is a template for change for this client that you're going to be working with. So can you see the defining elements are that the client is an active and core participant, not a passive observer or an occasional visitor. Okay, I'll come by. That you as a therapist have to motivate them, and that the therapist plays a very directive role in creating the treatment plan, which is then actually a template for change. So really making plans which the client can understand and adhere to and make sense to them. And so here, next slide, this is kind of the famous, triad that we all see, triangle of depression, which is what CBT is all about. Thoughts create feelings, feelings create behaviors, behaviors reinforce thought, and it kind of goes round and round. This is kind of like what we call a feedback loop, and it's vicious. And the next slide, I want to show you how this model works. And again, I'm including all of this in the PowerPoint because you can actually use this for psychoeducation. So look at this working model. So remember the ABC I told you about? So the event is you did not pay a bill and it has now gone to collections. How do you appraise the situation? I can never do anything right. I'm a failure. What is the affective and biologic arousal for you? You don't sleep, you have low energy, and you may also be crying. What is your behavioral inclination? I don't want to deal with it. It's too much stress. And what do? What is the maladaptive behavior? You withdraw, you avoid, you put your hand in the, you put your head in the sand and maybe stay in bed all day. This is the working model of CBT. And this is what you have to unpack with your client. So, next slide. So at the crux of it is you're going to help your client challenge their interpretation. So CBT emphasizes that it is not necessarily a situation, which is the bill going to collection. You're not paying the bill actually now being referred to collection, that causes the distress that a patient or an individual experiences, but rather it is the individual's interpretation or view of the situation that leads to this. So CBT works by learning how to challenge those negative thoughts. Remember, the thought was, I never do anything right, I'm a failure. And learn how to change unhelpful behaviors. So I would suggest, if you're doing a psychoeducation, taking the working model and taking the statement and trying to maybe working with your client to see how does this apply to that working model that we just shared. And here are some examples. I'm giving you an example, next slide, of how individuals react differently to the same event. In the working model, it was your inability or your having not paid your bill going to collections. Here it is, imagine someone close to you treats you inconsiderately. How do you feel? Person one, angry. That idiot has no right to treat me that way. Person two, depressed. This lack of consideration means they don't love me. Person three, jealous. This means they care more about someone else. Person four, hurt. I don't deserve to be treated poorly because I'm always considerate. Person five, guilty. I must have done something to upset them. Person six, anxious. This must mean they're losing interest in me. Person seven, happy. Great, now I can use this as an excuse to end our relationship. Person eight, annoyed. I'm not prepared to put up with this behavior. Person nine, disappointed. I wish they had been more considerate. Person 10, ashamed. They must have found out something about me. Can you see? 10 different interpretations, 10 different set of beliefs from the same external trigger. So I really wanted to bring that home to you by giving you this example. So with that background, next slide. When you're working with your clients using CBT, which I told you is the gold standard, you should socialize your client to the model. And I've been a therapist most of my life. I worked in community mental health program. And what was my biggest friend was a whiteboard. I always had a whiteboard in my office. And if I did not, sometimes I would have one of those little whiteboards that you can carry around with good markers and which you could erase. And I would be drawing diagrams and writing stuff on the whiteboard all the time during my sessions. And in some of our bigger rooms where I would hold group sessions, the whiteboard was such that you could actually print everything that you wrote on the whiteboard and give it to patients or clients. So very critical to socialize your client to this model. And depression is one of the top diagnoses for people coming not just to mental health settings, but also to primary care settings. It's one of the top 5 diagnoses in primary care settings is depression. So how much more important it is to socialize your client to this model. And these are simple statements which you can even put on a little sheet of paper. People prone to depression learn through their experiences a set of beliefs that when activated, that when that belief is activated, it leads to depression. These beliefs relate to some area of vulnerability, like failure or loss or rejection, so that they develop a negative view of themselves, their world, and the future. So whenever they encounter stress that impinges on these areas of vulnerability, those negative beliefs come into force, come into full play. Depressed people maintain negative conclusions about themselves by relying on these distortions in their thinking. Remember, I said cognition, cognitive essentially means you're thinking. And this depression feedback loop links the client's symptoms to their ideas and beliefs. That loop we talked about, the thoughts, your emotional reaction, and your behaviors. This is what you need to socialize your client into understanding. And again, next slide, I'm giving you this little triangle, the CBT triangle of what we just said, how that interacts with each other and causes depression. Next slide. So there are 3 major thinking errors in this model for people who are experiencing depression. They think the implications of a negative event will go on forever. Sometimes we call it tunnel vision. It's never going to get better. It's always going to be that way. That it will spread to all areas of their life. And they are to blame for some kind of inherent fault in them, whether they are a failure, they're unlovable, they're unworthy, they are stupid, whatever it is. So those are the 3 major thinking errors. And remember, the main feature of depression is that you systematically distort your experience in a negative direction, not in a positive direction. If you remember those 10 interpretations I gave you, of people looking at the same event, I think there were maybe 2 which were kind of in a positive direction. So what do people do? They are depressed people. They distort every experience in a negative direction. That means they're stuck in their default perspective. Why? Because overall, that's all they see. It's unrealistic and negative. And I call that your default perspective in people who are depressed. So next slide. We call this, in psychology, we call this an attribution error. This means if something goes wrong that makes you think negatively about yourself, you think that negative thought is true about lots of other things in your lives, and that it's going to be true forever. So we call this an attribution error. For example, if your boss calls you stupid for making a mistake, you think, I'm a stupid person and everyone will think I'm stupid. While someone with a higher self-esteem might think, that was a stupid mistake, but normally I'm pretty good at my job and my boss likes to bully people, so I shouldn't take it personally. Can you see the belief? The second set of belief was really in a positive direction, while the first set was by default the negative direction. And so we call this an attribution error, that if something goes wrong, it makes you think negatively. That's how you've been hardwired, almost like you've been hardwired in your brain. And so next slide. And so Beck, remember Dr. Aaron Beck, the founder and creator of CBT, created, it's called the Beck's cognitive triad, which I've alluded to several times already. He talks about people with depression have a negative view about oneself, that means they have a negative view about themselves. They have a negative view about the world, which is like the present. And then they have a negative view about the future. For example, the self, I'm worthless, I'm ugly, I wish I was different. The world, no one values me. People ignore me all the time. I'm always passed over for promotion. Something's wrong with me. The future, I'm hopeless because things will never change, or things will only get worse. So can you see? This is the triad, which is what Beck talks about, the cognitive triad of depression. Next slide. And I'm giving you some more examples about this triad. So for depression, for yourself, you'll be saying, I'm incompetent, I'm unlovable. For others, people do not care about me. That would be the present. And future, the future is bleak, or the future is dark. Nothing's going to change. You can see why people sometimes get desperate and take their own lives when this is what they are dealing with. And then look at the triad for anxiety. Self, your self. I'm unable to protect myself. I'm weak. Others, people will humiliate me because I'm unable to protect myself. And what is the future? It's a matter of time before I'm embarrassed. And this is really a triad for social anxiety. You know, I'm unable to protect myself. People will humiliate me. And it's just a matter of time before I make a fool of myself in public. So can you see how these interact and how they produce both anxiety and depression, or both? So this is all good stuff to actually share in your first session with the person. Next slide. And so I really want to move now to, remember, the crux of our training today is really about using the principles and techniques of cognitive behavioral therapy. And so there are basically two tools. One is called the action and activity schedule, and the other intervention is called a thought record. And we're going to kind of unpack both. So I'm going to begin with, next slide, going to begin with activity scheduling, which is a behavioral intervention of CBT. Next slide. Remember, it is CBT. So the B stands for behavioral. Kelly, can it move? Okay. So it's easier to start with behavioral. So this may be a good starting point for you and your client. And again, here is a way to kind of give context to this intervention with your client. Depressed people tend to withdraw from everyday life. And this passivity is actually a safety behavior, which in itself lowers, sometimes we call this avoidance, and we'll be talking about avoidance. So it lowers energy levels, reduces motivation, and confirms in the depressed person the view that they are best left to their own devices and ought not to be bothered. Just leave me alone. So what's the antidote? Activity scheduling is a tool for combating that passivity or that avoidance, and gradually helping your client re-engage in some of the routines of his or her daily life. At the same time, it allows for testing of certain depressive assumptions. Remember the first slide about Aaron Beck? He wanted to really create therapies which could be empirically validated. So you're also doing that in your therapy. You're going to help clients test some of their depressive assumptions. For example, I don't enjoy doing anything these days. I'm just a useless waste of space. So you're going to help them test that by creating this activity schedule. That is one reason. And the other one is really helping them go back to their routines and daily life, which kind of gets dropped by the wayside when you're avoiding and when you're really depressed and have low energy and motivation. Next slide. So what is this action schedule? Depression can undermine your will to get up and get things done. You might be avoiding chores or unpleasant tasks at work, and you may also find yourself resisting fun activities. You may just be avoiding it because it's so stressful that you'd rather bury your head under the blankets and stay at home than face whatever it is that you're avoiding. Using an action schedule is really great to start scheduling pleasurable activities like going to a movie, maybe calling a friend. Even if it seems hard at first, once your client commits to a specific activity by scheduling them, you are more likely to follow through, as opposed to leaving it kind of laissez-faire. Let's talk about it. Let's see if you do it. If you get an active commitment and you start an action schedule, it's more likely that someone with depression is going to follow through on it. So that is pleasurable. And in CBT, we also teach about scheduling mastery activities that give you a sense of accomplishment. So we do both. Pleasurable activities like going for a movie or watching a good TV show or calling a friend would all be considered pleasurable. And then there are activities of mastery. I cooked a complete meal today would be an activity of mastery. Or I went out and watered my plants. That would be a mastery activity. So you're really trying to move people into the direction of action. Next slide. And so how do we do it? We basically encourage the person to write down their activities on an hour-to-hour basis. And I have a schedule format I'm going to show you. And then you ask them to rate it for mastery and pleasure on 1 to 5, and I'll share the form with you. So it's very simple, but this is a basic intervention in CBT. So next slide. So how do you motivate your client to take action? Remember, I said that's part of the job of the therapist or the behavioral consultant or whatever your role is. Especially when your client is caught in this kind of this feedback loop of negative thinking, that they can't focus on anything else. So it's your job then to help focus on what they can do. And here are some small tips for them. I've just given you a list. You have to weave it into your sessions. For example, do the easiest step first. Think of something you have been avoiding. Bring it down into steps and do the easiest step first. Do the opposite of what you feel like doing. That's a motivator. If you feel like staying in bed and sleeping, do the opposite. Get up and do whatever the activity is. I love this last one. And I would have a lot of my clients chuckle. Do a little before avoiding. Catch yourself avoiding and then avoid your avoidance for at least 2 minutes. So do even a little bit of what you're trying to avoid before you absolutely avoid it. The other ones is make a stand. Just confront avoided projects head on. Surprise yourself. It may take you by surprise, maybe, to get up and ask someone, say, for a date. Or do something you've never done before. These are all ways to motivate your client. And I'm not saying every one of them works. And that's why I say, really, counseling, therapy, mental health is part science and part skill and experience. This one, next slide, I love this tip for taking action. Act as if. And that's why I put it on a separate slide. To feel better, act as if you're already in that state of mind. For example, when you start to act friendly towards others, maybe that's what you have negotiated with your therapist, you start to feel friendly. Although this seems to be like you're pretending or you're not authentic, you're acting the way you most honestly would like to feel. keep your thinking on your own best interest and act as if you were in your active self. So it's not pretending, but you're keeping your thinking on your best interest. You may have heard this in the addictions world. They talk about fake it till you make it. It's really this: act as if. And what they've also shown in some research is that fake it when you make it, till you make it, is that in some play, in some ways, our brain is the neuroplasticity of a brain. You're actually maybe even rewiring your brain. So I really like this act as if, and I've used it a lot with clients. Next slide. And this is an example, and I've given you my source for the book I've used at the very end. This is an example in therapy, and the skill is, so what? Keep going. So find what skill works best for your client and then help them practice it. And by the way, CBT is practice, practice, practice. Okay. And that's where that motivation, building that motivation. So client, I feel like I can't take any steps on my taxes. Therapist, here you can use the phrase, so what? Keep going. The so what gets you into acceptance, and the keep going instructs your passive mind to act and move towards a goal. Client, I complain about it, but don't do anything. When you catch yourself complaining, tell yourself, so what? Keep going. What should you do if you can't get out of bed because you feel hopeless? Client, say, so what? Keep going. Get out of bed and do something. And this was a simple statement that they practiced in therapy, and that the client was going to use every time his motivation dipped and he wanted to veer in the direction of negativity. He was going to say what? So what? Keep going, and kind of do the opposite. And so next slide. So here is kind of a simple action schedule. The internet is full of this. You can download it from anywhere, but I just wanted to show you it's very simple. The person actually records the activities and then gives it a M for mastery, P for pleasure, and actually rates it on 1 to 5. Like, number 5 would be the best. The best feeling, and none would be, and 1 would be, it's like a Likert scale. So it's very simple. You can get these all over the place, and this is a good place to start with very depressed people, is really creating this action schedule. Next slide. So moving from action, now we are moving to what the concept is called automatic thoughts. Remember, again, that triad, Beck's triad for depression. Clients with depression experience negative emotions. Often these emotions are due to the direction of their negative thoughts. Remember, that's the default setting. You want them to grasp how their negative thoughts affect how they think, act, and feel. And by the way, depressive thoughts are automatic, negative, illogical. And the more depressed you are, the louder and more prominent these thoughts are, the chatter in your head, the kind of room these negative thoughts are taking. The good news is, controlling these thoughts is a great way for you to feel better. So the first step is to actually recognize your automatic negative thoughts. Next slide. Ants. Automatic negative thoughts. They just come automatically into your head. You don't have to work too hard. Especially when a particular situation occurs. They happen spontaneously in response to the situation. They don't arise from reasoning, and there is really no logical sequence to them. So there's a stressful situation, automatic thoughts pop up, and it leads to negative emotion. And that's what an ant is. Next slide. So we teach the 3 R's in CBT for negative thoughts or for ants. Record, rationalize, replace. Simple. This is a good tip to print out and give to your client. Hey, this is what we're going to do. We are going to master the 3 R's. You're going to record or identify your negative thoughts, and then you're going to rationalize or rebut them, and then you're going to replace them with something which is more realistic. Simple. So record the 3 R's, record, rationalize, replace. Next slide. And I would sometimes even say, just press the pause button on negative thoughts. You know, we all have mental tapes that we play in our head over and over again. But some of us have learned to tune them out, lower the volume, or basically get rid of them. Several of us don't. We still have those playing at a very loud volume. And we tend to believe these stories, these narratives, though they might have very little basis in reality. And so remember, I just talked about the 3 R's. We teach you to identify your thinking errors. We teach you to challenge those thoughts, we teach you to recognize that your thoughts cause your feelings or how you feel, depressed, anxious, worried, and that feelings are not facts. And we're going to talk about that last bit. Next slide. So you are actually teaching your client to challenge their negative thoughts, which is, what is it? Their default setting. Especially when you're depressed, it becomes even louder, and it takes up all the space in your brain. When they're depressed, they think circumstances have to change before they can be happy. But guess what? Changing circumstances can take time and a lot more effort. However, the choice to think differently can take place almost instantly. And that's the message that you need to give. Next slide. So we call this, the fancy term is cognitive restructuring, which basically means you are changing and reconstructing your thoughts. This exercise was designed to help people examine unhelpful patterns of thinking and devise new ways of reacting to a problem situation. And cognitive restructuring involves keeping something called a thought record. And we're going to look at that. It's a tool we use in CBT, which is a way of your client tracking their dysfunctional automatic thoughts. Remember I said they just pop in, those automatic thoughts. And then teaching them to recognize it, and then more importantly, devising an adaptive alternative response. That's what cognitive restructuring is. Keeping a record of what your dysfunctional thoughts are, and then devising a more adaptive alternative response or a rebuttal. Next slide. So when we are teaching this, here are some important questions that you teach your client to ask. What's the evidence that this thought is true? I'm a complete failure because I lost my job. Can this be looked at objectively? What's the evidence for and against it? What's another way of looking at it? Losing your job can be looked at as a way of getting a better job or an incentive to learn a new skill so that you can perform your job better. Even if it is true, how bad are the consequences? So even if I lose the job, I can still choose to accept it and be okay with it. Typically, when you're depressed, you use thoughts like, they didn't like me as evidence I'm no good. So can you see? You teach these set of questions to your clients to actually challenge their default thinking. What's the evidence? Is there another way to look at it? And even if this is true, how bad are the consequences? Why? Because people who are depressed think they will not be able to cope, that it's the end of the world, that life will never be the same. that it will go on and on and on into the future. That's what we want to change. Next slide. And so there's another skill we teach, which is called Socratic questioning. And what is Socratic questioning? These questions are Socratic because, like Socrates, the great Greek philosopher, they expose a negative argument to rational investigation. So you may be very strongly attached to your negative self-talk, that chatter in your head. You may have been telling these things to yourself for years. And it is difficult to give it up both as a habit and a belief. My gosh, what am I going to do? Will I have a blank slate in my head? So it is important that you subject your thoughts to rational scrutiny. And the hope is that you will then weaken the hold of this negative self-talk by exposing them through this use of what I'm calling, Socratic questioning. If you don't like the term Socratic questioning, you don't want to use it with your client, you can just use these questions. Next slide. Which are something similar to those earlier 3 questions. What is the evidence? Is this always true? Has this been always true in the past? What are the odds of it really happening? What is the very worst that can happen? What is so bad about it if it happened? What would I do if the worst happened? Am I looking at the whole picture? Am I being fully objective? So really teaching this skill to your client. And can you see how directive you have to be and how much of a cheerleader and motivator you have to be so that your client is not a passive visitor or a passive observer, but very much working with you. Next slide. And this is what a thought record looks like. So what is the situation? What was your feeling? What was your automatic thought? That ant, which is automatic negative thought. And what was the thinking error? And we are going to look at thinking errors very shortly. For example, situation, you were at work. You suddenly felt sad. Your automatic negative thought, my life is over. I have nothing to look forward to. And what was your thinking error? Either or thinking. And we are going to look at that right now. Next slide. So we teach this to all of our clients. And sometimes you can do it as a standalone. I mean, sometimes we use this in group where we are teaching mental wellness. To recognize thinking errors. And so this again comes out of Beck and also, teaching your clients what these thinking errors are. And there are many of them. And I've given you 3 slides, which basically cover all of them. I'm not going to go over all of them. For example, overgeneralization, which is a very common one. You see an isolated incident as proof of a widespread problem. I always make stupid mistakes. You may have made one stupid mistake, but you overgeneralize it to your entire life. You disqualify the positive. You transform a neutral event and even a positive event into a negative. Or they're just being nice to me so that I'll feel good. Totally disqualifying. Hey, there may be something really good about you. Mental filter is very common in depressed people. It takes a tiny amount of negativity and you paint the entire situation with doom and gloom, because that is your mental filter. That is your default setting. And then all or nothing thinking, or I call it black and white thinking. You either succeed or you fail. There's nothing in between. There is no gray area. There's no points for effort. No gold star. You're a failure. You're dumb. You're stupid. Next slide. And then there are lots more, jumping to conclusion, magnification, emotional reasoning. For example, you're feeling overwhelmed and hopeless. That's a feeling. Therefore, my problems are impossible. And you see the emotional reasoning, that's wrong. Next then should statements. Next slide. The little word should can create all sorts of havoc. Replace it with like to or get to. Labeling and mislabeling. Mislabeling. Anytime you say to yourself, I'm a idiot, I'm a failure, followed by a negative noun or adjective, you're labeling yourself, or actually mislabeling yourself. And then lastly, personalization. You take responsibility for action of others or every event that has happened, which is outside of your control. And here, personalization is actually the root cause of guilt and shame and self-blame, that you take responsibility, even when it's clearly not your responsibility. So really teaching your client to recognize these common thinking mistakes. Next slide. And here I've given you some examples. Nobody likes me. Mind reading. I'm the worst student in the world. Labeling. I'm causing a problem for a lot of people. Personalization. At the bottom, the last one. I'm so fat I could never succeed in life. All or nothing thinking. There's catastrophizing. I failed to put out the garbage bin again. The world will end. So I've given you some examples, and these are good ways to teach your client to recognize what their thinking errors are. Next slide. And remember, we talked about the ants. This is what you want your client to recognize, identify the negative thought, and then come up with a more realistic and optimistic thought. So now we are looking at what we call, next slide, the extended thought record. Remember, the earlier one stopped at thinking error. The extended thought record is what were you doing and thinking? What were you feeling? What went through your mind? What was the thinking error? What's the evidence? What's an alternative explanation? So what? Take action. How can you test this out or improve your situation? And then what was the outcome? Now, how do you feel after going through this process? And this is called the extended thought record. And this is really at the crux of CBT. Is, you're recognizing your thinking error. You are kind of rationalizing, remember the 3 hours. So what's the evidence for this thought? Is there an alternative question? Even if it's true, so what? And then action. How can you test this out or improve your situation for whatever triggered it, in that first column? And then lastly, after you do this whole process, how do you feel now on a 1 to 10 scale? 10 means you're absolutely feeling super good. 1 means you're lousy and nothing has changed. And so this is also a key technique in CBT, is the extended thought record. Next slide. And this is a CBT technique which I like, treating thoughts as guesses. So you're teaching this to your client, that people think thoughts are facts. They're not, they're thoughts. So one technique to reverse this negative feedback is to relate to thoughts less as facts and more as guesses. The reality is that many of the thoughts we have are not facts. They are merely conclusions that we have developed in response to a limited set of facts. You have just come to that conclusion. The key is to begin to think of thoughts as guesses or hypotheses and not as facts. Because once you think it's facts, then it is hard and fast. Nothing can change, because that's what facts are. But the reality is your thinking is based on limited data, And so treat it more as a hypothesis. I'm going to test out and see whether this hypothesis stands. Because that's what we do, by the way. You test a hypothesis before it becomes a scientific fact or a theory. So I really like this. The other, next slide, the other thing we talk about is dropping negative thoughts. Clients don't have time all the time to complete those thought records. It's very good to encourage them to do it. Once they understand that the negative thoughts are not true or are not useful, they can simply acknowledge them and let them go. They will gradually begin to notice a pattern in their thinking. So if you want, they can simply count the thoughts, such as putting down dashes on a 3x5 card. Noting the thought and then releasing it prevents the client from reinforcing it by fighting it or resisting it. So we teach this technique of negative thought dropping, just letting it go. Because you can't be keeping voluminous thought records all the time. And remember, we said these are automatic negative thoughts. So even just acknowledging them, even for a second, and then letting it go without dwelling on it, because that's when you reinforce it. So you actually teach this to your client. Next slide. So a big part of depression is what we call avoidance. And that is at the heart of depression. That is why we find depressed individuals failing to keep agreements of any kind. Maybe it's a therapy agreement, or it could be an exercise agreement. Because why? Because avoidance is at the heart of depression. And avoidance makes depressed people feel that they have lost the ability to get things done. And that's a notion that wreaks havoc on their self-esteem. So it's very important actually that you understand why depressed people avoid. Avoidance often begins as a very natural response to stress. We don't want to feel bad, so we avoid doing the things that make us feel bad. So in the short term, we may feel some relief, we may feel safer, we may feel less stressed. For example, the phone rings, you feel anxious, you don't answer the phone because you know who it is. You feel a bit calmer. So can you see short-term advantage? Usually we avoid because it feels better in the short term, even though we know that it is likely to cause problems in the long term. And so what happens with depression? We go for the short-term advantage, much to our detriment. Next slide. So how do you help your client bust avoidance? What can you teach them? What is the alternative coping? You want to help them change this harmful avoidance pattern, which is often like a passive response to a triggering event, which is very upsetting, into an active chosen response. It's not about getting rid or ignoring those painful feelings. Rather, it is facing them in a new and more engaged way. So it's not that you won't feel afraid to answer the phone, but it's rather than avoiding it and running away, you will learn some techniques to face it in a more directive and engaged way. By asking these, what's in my best interest in the long term? What way of behaving will be most in line with my values in this situation? What opportunities does this situation offer me? Maybe it will teach me some coping skills to deal with my boss who's calling me on the phone. So encouraging your client to ask these questions to help them bust avoidance. Next slide. And then really enhancing their motivation by telling them what are the advantages for taking action instead of avoidance. So taking actions moves you from where you are to where you want to be, and actually may improve your mood. Instead of being fearful every time the phone rings, you get a knot in your stomach, or you have a diarrhea, you feel really lousy. What if you were to take action, answer the phone? It may just help you resolve the issue, and it may improve your mood. With each action against avoidance, you will find insight and new awareness that can help you continue to move forward. Taking action actually combats thoughts and feelings of helplessness, that I have no control over this. Avoidance of what needs to be done to reach your goal creates tension and drains your energy, because you know you're not doing what you need to do. So once you confront this avoidance, guess what? You may have room to relax that tension that you feel. And we teach this to clients. Taking action on what you've been avoiding is one of the best ways to get undepressed. Next slide. Now, remember, we talked about beliefs that underlie negative thoughts. So we encourage clients to use the same methods of spotting automatic thoughts to identify and alter underlying core beliefs about themselves, about the world, about the future. Remember that Beck's triad of depression. Automatic thoughts are generated from our belief systems. What is the belief system we have created? Beliefs such as I'm responsible for everyone, or unless I'm really beautiful, I'm nothing, or I'm stupid and I always will be stupid. When a person is depressed, they have an opportunity to see the deeply ingrained beliefs that predispose them to depression. I'm unworthy of love. I'm a failure. And next slide. And here is a list, inventory of some common beliefs. I'm a failure. I'm unlovable. I'm a victim. I'm not good enough. I'm flawed. I'm actually a bad person. I'm really unlucky. I'm unworthy of this. I am doomed. There is no hope for me in the future. Can you imagine living with these core beliefs? Next slide. And here's a simple exercise I would give my clients. What is your core belief about yourself? List 3 pieces of evidence contrary to your core belief. So this is something to encourage your clients to identify. And that's a critical part of CBT, is recognizing what are the core beliefs. Next slide. And here are again set of questions to really bring out what your core beliefs are. Questions that weaken beliefs. Just raise the question. The answer will come on its own. Here are some questions. Where is the evidence that I need to be loved by everyone all the time? Do my bad feelings come from thinking that I need to prove I'm good enough to everyone? Am I taking the need to be special out of context here? Do I honestly need to be famous and admired by everyone to feel good? Am I confusing my present with a past belief that I needed to be important? Is there a real need to be in control when I consider the big picture? Is getting the love I demand good for me in the long run? Is the belief I need to be strong at all times undermining my self-esteem? Is my need to be secure a fantasy? Do I really need that all the time? So these questions even just raising these questions, the hope is that they will weaken your beliefs and that they will challenge your core beliefs. Next slide. And here is an example in therapy. Client, the thoughts just come automatically. That's why they're called automatic negative thoughts. And by the way, the thoughts are connected to beliefs. Therapist, that's right. But you can still practice letting go of thought passage and let the thoughts flow by. They don't have squatters' rights. I love that. They don't have squatters' right in your brain and your mind. This is about that thought dropping that I was talking about. Therapist. Oh, client, I have an urge to respond to them. Therapist, yes, responding to them is like smoking cigarettes. Every time you give in to the urge, you are reinforcing them through attention. By not reinforcing them, they will start to fade away. Client, it's still hard. Therapist, let's practice. Close your eyes, and every time you see a thought, say the word thought and let it pass by without a second thought. So this is that thought dropping that I talked about. Because it's a struggle, because these are automatic negative thoughts. And when you've had a lifetime of belief and habit, it's difficult. Next slide. And here are some other tips to control the chatter in your head. By derailing your negative self-talk train with what this author calls a active reset. Seizing control of your self-talk track and learning to stop negative thoughts before they gain too much momentum takes discipline and repetition. And so you have to employ an active reset approach. When the negative thought train comes rolling by, stop and acknowledge. Stop it. This is negative thinking. Question, why am I thinking this way? What evidence do I have to support this negative thought? Reframe. How can I reposition this issue and look for the opportunity? Act. Here's what I'll do now. And then step that groove this into your brain to make this behavior repeatable. Reflect. What did I learn from turning my negative thought into a positive opportunity? So this is a good recipe or a template to kind of do that active reset. Next slide. And so here is core belief work in action. And core beliefs are kind of like the lenses through which you see the world. You can have really dark black lenses, or you can have rosy colored, lenses. So you meet a person and think about asking them out to coffee. That's the situation. What's your core belief? I'm not worthy, or I'm ugly. Consequences, thought. Why would they go out with me? Behavior, you don't ask the person out. Look at the other way. You meet the person and think about asking them out for coffee. Core belief, I'm not worthy. Thought, we just might have fun if we go out together. Behavior, you ask the person out. Can you see the difference? I know I've distilled it to its simplest form, but sometimes simple makes sense. And so here it is. Here it really shows you how your core beliefs underline your thought and your behavior and action. So next slide. So in the next few slides, I just want to go over some techniques, which is kind of like a bag full of techniques which you can pick and choose. Next slide. Here are some truth-based techniques that you can use. And let me tell you, I've used all of these. I used to be a big one for examining the evidence, doing little experiments to see whether it's true. And then the survey technique in particular is really great. I mean, I've used it a lot. The survey technique is you do a survey to test your negative thought. For example, if you think you are shy or weird, you can ask several of your friends if they've ever felt shy. And if the answer is yes, you will discover that most people feel shy at some time, and they're not weird or stupid. So that's like a survey technique. There are little experiments that you can encourage. One client of mine used to always say that people are always laughing at me. That was his belief, because I'm kind of not very attractive. So the experiment was, he was supposed to go to a mall. He was supposed to sit in a busy area where people could see him, and then on a 3x5 card, he was supposed to put those hatch marks of how many people he saw who actually turned to him and laughed at him. That was the experiment. And guess what? It was 0 people. So what did the experiment show him? Really, it's in your head. It's not happening. It's not valid. What we did was we tested his thought to find out if it was valid. And then a lot of time, examining the evidence. What is your evidence for this claim? That nobody loved me. Show me the evidence in your workplace. Then downward arrow, I've used that a lot. This helps you to identify what we call self-defeating beliefs, remember? So we actually, I wish I had a whiteboard, which I don't right now. We draw a downward arrow under a negative thought and then ask, if this thought were true, why would it be upsetting to me? What would it mean to me? And then you come up with a new negative, and then you draw another arrow, and you continue to do these arrows till you come to the underlying core belief, which is at the heart of the suffering that the person is experiencing. And this is called the downward arrow technique, which is really you're uncovering the core belief. We already talked about what if. But here it is really you're again unveiling kind of the fantasy at the core of the fears. You keep asking, what if? Okay, what if it happened? What is the worst thing that can happen if it were true? And then finally you ask, how likely is it that this will happen? And could you live with it if it happened? The fantasy is, no, I will just collapse into a big bubble and, kind of it will be annihilation. Next slide. This is a very common one, compassion-based technique, which is called the double standard technique. Instead of putting yourself down, you can talk to yourself in the same compassionate way you would talk to a friend who is upset. Would I say such harsh things to a friend with a similar problem? What would I say to him or her instead? And then saying those things to yourself, as opposed to, I'm unworthy, I'm unlovable, you're stupid. Would you say that to a friend? No. Because you won't have friends then, correct? Next slide. Logic-based techniques. Thinking in shades of gray. Remember that black and white, either or. You evaluate them more realistically and maybe live in the area of the gray zone. Live with a certain amount of uncertainty. Live with non-perfection. And then process versus outcome. Evaluate our performance based on the process, the effort you put into it, not necessarily only the outcome or the result. Your preparation and hard work are always within your control. Often the result is not. So giving yourself credit for the process that I put in the effort, I did my best. Next slide. And here again are questions to help find evidence that does not support. Sometimes we call it a hot thought. That's a kind of thought which is negative, but that's kind of very prominent for you. Have I had any experiences that show that this thought is not completely true all of the time? If my best friend or someone I love had these thoughts, what would I tell them? When I'm not thinking this way, do I think about this situation differently? Why? 5 years from now, if I look back at this situation, will I look at it any differently? This is kind of the perspective question. Are there any strengths or positives in this situation that I'm ignoring? Am I blaming myself for something over which I do not have complete control? Next slide. These are questions to promote that cognitive restructuring. Remember, rationalizing and replacing your errors. Are these thoughts helpful? Do these thoughts actually help me feel better? Do they help you behave more adaptively? Do they improve your self-esteem? Do they help you interact successfully with others? Do these thoughts contain cognitive distortions or those thinking errors, that I shared with you earlier, 10 of them? Are these thoughts consistent with the evidence? Are there alternative explanations? Always consider whether there are other explanations for an upsetting situation, as opposed to going to your default explanation, which is, guess what? Always negative. What would one say to a friend in this situation? Asking this question encourages you to be more generous and even-handed in your view about yourself. How did I learn to think this way? For example, I learned to believe that the world was full of unending burden and obligations because my mother believed this. But I don't have to accept her worldview. I can develop my own now. Next slide. Remember, we talked about thought stopping or dropping the thought. Identify what is that bothersome thought that you're having a really hard time. And then ask these questions. Is this realistic or unrealistic? Is this productive or counterproductive? Is this easy or hard to control? How uncomfortable does this thought make me feel? How much does this interfere with my life? Next slide. And again, this is, I gave you the whole list of cognitive distortions. These are, again, a list which are, used a lot, which is a shorter list. We sometimes also call these, cognitive bias or cognitive errors or cognitive distortions or thinking errors. And, here again, there's a nice list that you can use. It's a shorter list that you could use with your clients. Next slide. With that said, we also want to talk about screening tools. What tools do you use in your therapy sessions to assess at the beginning of therapy the severity of your client's depression? You can use the PHQ-9, you can use the geriatric depression scale if they're older, you can use the Beck depression inventory, but don't stop there. Next slide. How can you use screening tools to actually measure outcomes? What are the outcomes you want to measure? Symptom severity. Is your client responding to your treatment? So doing it maybe every 4 sessions. I'm going to give you the PHQ-9 again to see whether you've responded to my treatment. Does it improve their quality of life? Is your treatment efficacious? If they're continuing to be severely depressed, you need to pause and think, what do I need to do differently? What am I missing? So I'm wondering how many of you use screening tools to measure the outcomes of your therapy? Because really at the core, that's what it is. Yes, screening tools can also be used to identify a disorder, but it is very much also used to see whether your client or your patient is actually improving or responding to therapy. And so here is this very brief case study, and then I have a set of questions, which I'm hoping you will just put your answers in the chat box. Mr. Down has been feeling particularly low for some time. He spends most of his time in bed, and when he does get up, he does not feel he has the energy to do anything. He tells you that he was feeling particularly low this morning when his wife informed him that she was taking the children out for the day. He said that he thought, she didn't bother to invite me. I'm a useless, pathetic failure, and my wife and kids agreed. Here are my questions. Please put them in the chat box. Number one, what condition is Mr. Down likely to be suffering from? Next slide, Kelly. What thinking error is being discussed in that little case vignette? What CBT techniques would be helpful for Mr. Brown? Let's take maybe 3 minutes and let's see what the answers are. I'm seeing someone wrote the condition is depression. Anyone wants to venture what's the thinking error? Remember, he said, she didn't bother to invite me. I'm a useless, pathetic failure. And my wife and kids agree. Someone said overgeneralization. I would also go with black and white. Mind reading, excellent. Arbitrary inference, personalizing, jumping to conclusions, very good. What CBT techniques would be helpful? What techniques would you use with Mr. Downs? Thought record, excellent. What else? How about an action schedule? Because he's in bed all day, not able to get up, he feels he's missing out on life because his wife thinks he's a failure. So maybe an action schedule. Someone said thought record. What else? So goal setting for behavioral activation. Maybe even going over all of the thinking errors, and how those thinking errors are really kind of his core beliefs about who he is. Yes, someone's saying identifying and challenging his beliefs and teaching him how to do that. Yes, a thought record does do that. The extended thought record does that. So great. Thank you for participating in it. So before we end, next slide, I have a very brief reflection. Is there something new that you've learned today? And what is one thing you will implement in your practice starting tomorrow? If there's anyone bold enough to put it in the chat box, I would really appreciate it as a trainer. What is there anything new you learned today? Even if it meant it just kind of reiterated old learning. And then what is something that you will change in your practice, maybe right away?
Nirmala, this is Angela.
Yes.
I just want to weigh in that this would also be a good time to put some questions in the Q&A box.
So while people are thinking to do that, I'm going to ask Kelly to play a video that we have. It's a very short video on automatic negative thoughts.
Excellent.
Today, we're going to talk about ATs, also known as automatic thoughts. They're those destructive and unreasonably negative thoughts that you have that make things go from bad to worse. Avoiding ATs feels as impossible as avoiding red lights when you're running late. You're going to hit one or two, or every single light from your house to work on that morning that your report's due at 9 a.m. and your boss is already on the edge and you might just get fired and then get evicted and... See? automatic thoughts can pop up and escalate as easy as that. Regardless of reality, ATs are the things that help you build a couple of red lights up to an Armageddon-scale catastrophe in a matter of seconds. Today on Wellcast, we're going to show you how to manage those harmful automatic thoughts with healthier, rational ones. And we're going to use our triple R exercise. You are going to record, rationalize, and replace your ATs. But first, how serious are ATs? A study at UCLA shows that people who got caught in cycles of automatic negative thinking became clinically depressed, self-critical, and less successful in both their work and personal lives. According to Dr. Glenn Scaraldi, these negative, disordered ATs fall into 13 categories, all of which take a toll on your mental health. Here are some of the categories. Assuming or mind reading. Like when you are sure someone is mad at you, even though you haven't spoken to them just because they walked in and didn't say hi. Shoulds, must, and oughts. Those are the insane demands that we make upon ourselves in our quest to be impossibly perfect. The fairy tale fantasy, where we demand an ideal for our life and decide that anything less than that ideal just isn't fair. Overgeneralizing. Nobody likes me. I always ruin everything. And finally, catastrophizing. When you take a little problem and turn it into a big, terrible, life-changing event. How do we stop ATs? Good question. And the shorter answer is we don't. But by being conscious of the fact that we're having them and working to replace them with rational thoughts, we can keep them from endangering our mental health. And that is today's exercise. All right, everybody, take out your Wellcast journal. It's time to learn the 3 R's. Step 1, record an upsetting event. When something upsetting happens during the day, describe it in your Wellcast journal and record it in excruciating, painful detail. For example, today I found out that I got a C on my midterm. Step 2, rationalize. Now it's time to think about the automatic thoughts associated with the event. Pause and print this chart. In column 1, write down each AT you had about the upsetting event. For example, I am never going to graduate. In the second column, try and label each distortion. Some ATs might be rational, but most won't be. They'll most often fall into one of the categories we discussed. I am never going to graduate falls into the category of catastrophizing. Step 3, replace. In the third column, respond to each distorted AT. Talk back. Get those negative thoughts off your chest. And if it's hard to do that, try to imagine what you'd say to a friend who is struggling with their own AT and say it to yourself. When you're responding to those ATs, ask yourself some questions like, what's the evidence for this response? Is this a believable outcome for my situation? Will the world end if I get a C on this midterm? Of course not. So as time goes on, and you're more used to responding to your ATs instead of letting them take over your life, you should be able to replace those ugly negative thoughts with more rational ones. Let's recap. To keep your automatic thoughts from ruining your mood and running rampant, you're going to record upsetting events, rationalize them by addressing each irrational thought, and replacing the irrational automatic thought with a rational one. The world is not going to end.
Tweet us at WatchWellcast, email us at watchwellcast@gmail.com, or leave a comment down below. We'll see you next time.
Thank you, Kelly. And I will ask Kelly to also send the link to the video if any of you want to use it in your groups. I just thought it was great. So, I have the book I used for my presentation is in my slide and under resources, and so is my email address in the very last slide. If you can just move up. So it's Overcoming Depression, a Therapist Protocol. There's also a client's book. Feeling Good is David Burns. A great book that I used to use a lot when I was a therapist was Mind Over Mood. And here is my email address. Any of you are welcome to write to me if you have a particular question or a concern. And with that said, Kelly, we can just go back to our gallery view, and Angela and Kelly, I'm open for comments, questions. We have some time. Please let me know if there are any questions or just comments.
Well, hello again, everybody. This is Angela. And we do have one question, well thought out and detailed filled. So Claudia Schroeder writes, a lot of older adults have had negative, hard experience in their lives that are true. They've lost their health, partner, home, work, possibly estranged from family. How do you acknowledge this pain and loss and also counter it?
So, for older adults, one of the evidence-based practices is also ITP, interpersonal therapy, which very much addresses those life transitions and the lifetime of maybe pain leading up to an accumulation of losses. So, CBT may not be the most appropriate intervention at that point. So take a look at ITP, interpersonal therapy.
Wonderful. That's very helpful. I'm writing that down as we speak. We do have time for more questions. I'm not seeing any in the chat or in the Q&A. Kelly, I don't know if you found any in the chat box that wound up there by accident.
Or even just comments, if anyone wants to comment on anything I said or thought, or how you've used it, in your practice. So many of you said you do CBT. How did this kind of align with your work? What's your experience been as a CBT therapist? This was my bread and butter, for both. I worked a lot with anxious and depressed people in my practice. So
I'm wondering how many of our audience are actually working with older adults or are maybe putting a toe in the water and wanting to learn some more so that they can shift their focus over to older adults. Anybody want to join in? You can put that in the chat box. Tyson's here, Tyson Lancaster. Tyson, can we take you off mute? Can we add you into the conversation? If you're willing to be added in, yes. Kelly, can you bring Tyson on?
Hello, hi, can you hear me?
Yes.
Yeah.
Hi, how's it going?
Tyson, for those that haven't met you yet, why don't you tell us who you are, what your role is, and how much work you spend in the world of CBT and all things behavioral?
Yeah, I spend pretty much all my time behavioral, actually. So my name is Tyson Lancaster. I live in Eugene, Oregon, and I work for an organization called Visions, and we provide, as an organization, we provide behavior support services through aging and people with disabilities, or seniors and disability services. And our services are Medicaid waiver, and we are referral based through each county, but we go in and we talk. I guess we have two legs of our service. We provide functional behavior assessments to address what the behavior is and what is happening, and then we follow that up with a positive behavior support plan that really works on identifying what the how do we address this behavior and really work towards becoming more proactive to prevent the behavior to meet that client's needs versus putting out the fires and always being reactionary to it. But in our support plans, we talk about the proactive approach, but also the reactive approach, because regardless of however much intervention and proactiveness you have, you're always going to have some sort of fires to put out and behaviors to kind of address, or I guess more needs that need to be addressed acutely. So This is all really wonderful stuff. I've seen a tremendous rise on the residents and clients that I work with who are having these negative thoughts, and they're needing more CBT, behavioral activation, to get up in the morning, get going, have that sort of fulfillment and self-determination throughout the day. And the action schedules that Nirmala was talking about have been just fantastic. But these, the more cognitive distortions is really a good approach to it, and really being able to sit down and work with the individual or the client one-on-one to kind of work through it. So it's fantastic.
So you brought up a resource.
I did, yeah. So there's an app called Thought Diary, and it's in the Apple Store, and it is it's CBT, so cognitive behavioral therapy based, and it really does a lot of kind of what that that video that just came up, about automatic thoughts. So it has a daily check-in that you can do, and it says, how are you doing today? You can do that just one time per day. You can do it multiple times per day, and it's really a fantastic a tool. Yeah. You can check in, you can do another check-in, and it says, how are you? And it has 5 sort of smiley faces, from negative to positive. And then it's all color coded. So it sort of shifts all the colors. So if you have a positive emotion, it says, oh, well, what's the positive emotion that you're feeling? And it gives you 2, 4, 6, 8, 10, 12, 14 different ones, but you can also customize more. And when you click on that, you kind of go through this, and it just prompts you, what is this? What's what's your feeling? But then what is contributing to this feeling? Is it family, friends? Is it love, work? There's school, sleep, exercise.
Sounds pretty robust. So, I'm wondering if we can bring some other folks into the conversation.
So there are 2 other apps which I would also highly recommend. They're free. One is CBT I for insomnia. It's free to download. Even though it is for insomnia, there are lots of tools there that you can use for, other, not for insomnia only. So it's called CBTI as in India, and it's free. The other one is called My Strength. Now, I don't know if that is free, but lots of mental health programs in Oregon have purchased it as an adjunct to therapy for their clients. So check with your particular mental health program, whether they have My Strength. It's lowercase my, M-Y, uppercase S strength. So it's like one word, My Strength. And basically My Strength is CBT. So checking on that, and that CBTI is also free. Free to download. So those are, and there's also one that comes out of Washington. I'll have to look it up. It is for trauma. It is also free to download. It's from the VA, Veterans Administration. I'm blanking on the app right now, but that is also free to download. And these are really like a mix of skills. My Strength is CBT, and obviously CBTI is also CBT, but the veterans one is kind of like a mix. So, and these are all free to download.
There's a lot out there. You just need to know how to find it.
So one question I'd had to individuals in the first was, do you all get coaching during supervision? Many of you are maybe new or younger professionals coming out of school. Some may not have had in-depth training on CBT, and I'd ask how many of you actually get supervision from your supervisor, like clinical supervision, not for licensure, but for your daily work. And I think there was a mixed response, because I know in my work, when I was a young clinician, nobody provided me with clinical supervision. I had to learn it all on my own, or get my own peer learning going, with my peers. I wasn't getting it from my manager or supervisor who were not trained clinicians, they had more of a generic MSW degree or something like that. The other thing is we asked, would you like coaching? Would you like to develop your skills in CBT? And again, it was kind of like a mixed response. So either you all are getting it really a lot and you're very pleased with it, or you don't see the value in really, maybe using it with clients. That's how I'm interpreting it. I could be way wrong. It could be a thinking error on my part, but that's how I'm interpreting it. So.
Quiet audience today.
Looks like Jennifer is writing furiously. I mean, Jennifer Wells. So I can see something she's writing in the chat. So
what Jennifer wrote was, the way I read it was, if I wanted to coach.
No, oh, I see. No, I was asking, would you all in the audience, would you like coaching? Would you like a coach, like once a month, to come and coach you on using CBT techniques? Sorry, I misinterpreted it.
Are
Yes,
you
so
offering, Nirmala? Nirmala, are you offering?
No, I work for OHA. We can look at many options.
Okay.
I can offer myself, but there are lots of other options too. Maybe looking at developing an echo clinic for CBT. I mean, there are lots of options. So
excellent. Okay.
What my fear is, that we are having a workforce crisis in Oregon in behavioral health. Very often, we have very young clinicians coming out of college and, grad school who may not have vast experience and are working with very complex clients with very little kind of clinical supervision. And then it's very easy to get burnt out and kind of hopeless, about the situation. So I'm trying to see how can we plug those, kind of plug that up in terms of providing you with the kind of clinical supervision that you need, not administrative.
That sounds like quite the gift. So
yeah, to kind of hone your skills, like I said, really therapy is one part science and the most part of it is really skill, skill and experience. So, I can give you a set of questions to ask, but the way you ask, the way you engage, the way you motivate really comes out of developing a skill.
Well, we've had a few folks chime in that they would definitely be open to that, to receiving some coaching on how you actually make CBT work for you.
Okay. Yep. Well, thank you all. I know some of you were expecting this to be maybe a different kind of presentation. I think we've done so much on just recognizing depression, risk factors, that this time I thought, let's take another approach and really provide, information or a training on an evidence-based best practice. I know I also teach behavioral activation, which is again very clinical. So if Angela, maybe the fall series, if you feel people may also benefit again from a behavioral activation training, I'd be happy to provide that. So,
well, that sounds wonderful. Definitely sounds good. And again, we're bringing Nirmala back at the end of the month for Hoarding, older adult focus. That is our mission, is to focus on older adults and adults.
And guess what? I will be teaching CBT for hoarding. So if you're interested in more CBT, come to that training.
There we go. Much needed training too. So we need to thank Nirmala and wrap things up here so we can let you all get on to whatever you've got going at the top of the hour.